grand panel case-based discussion on sinonasal malignancy, which will be moderated by Dr. Prathamesh Pai, sir, leading senior consultant head and neck skull-based oncosurgeon. The esteemed panelists for the discussion are Dr. Chirag Panchal, Dr. Deepa Nair, Dr. Diva Shah, Dr. Ramandeep Vark, Dr. Rushabh Kothari, Dr. Sarbani Ghosh, and Dr. Shaili Mehta.
Why don't you all sit that side? It'll be easier to talk to you. Okay. Yeah, easier. Keep one or two chairs there. Keep the chair, one more chair there. Good evening, everybody, and welcome to the last panel of the day, followed by we have two important lectures. We have had a lot of discussion the whole day on the management of paranasal sinus tumors, and we have the whole panel here. Can you please identify yourselves, please?
Hello, I am Dr. Chirag Panchal. I am a neuro and spine consultant neuro and spine surgeon at HCG Astha Cancer Center, Ahmedabad.
Yeah, go ahead.
Hi, sir. I'm Ramandeep Virk. I'm an ENT surgeon at PGI Chandigarh. I'm an endoscopic endonasal surgeon. Full disclosures, sinonasal malignancies doesn't form the bulk of my work, but we'll see what the best we can do.
I'm
So
Dr.
you're a
Rushabh.
phenomenal endoscopic surgeon. That's what we want.
I'm Rushabh Kothari, medical oncologist, Oncovin, Ahmedabad.
You're the most important person on this panel.
Hi, I'm Sarbani. I'm a radiation oncologist at TMH Parel.
I'm Deepa Nair. I'm a head neck surgeon at TMH Parel.
Diva Shah. I'm a senior consultant radiologist at Gujarat Imaging Center.
I'm Dr. Shaili Mehta, and I'm an oncopathologist at Gujarat Cancer and Research Institute.
Okay, the second most important person on the panel. The first, yes. So this is what we are dealing with. We have heard about this whole day, that we got such a wide variety of histologies that really we need to understand what histologies we are dealing with prior to understanding how to treat them. In contrast to the maxillary sinuses, the nasoethmoid tumors are predominantly non-squamous, and we need to really understand how we are going to manage these. We all heard about the location of tumors and their importance, and a very simple way for us surgeons to understand what histology we may be dealing with is just understanding where is it in relation to the turbinates. Medial to the turbinate, you would expect neuroendocrine pathologies, Eustachian neoplasmas. Lateral to it, squamous cell and adenocarcinomas. Something in the clivus sphenoid, you would expect to have chondrosarcomas, chordomas. Sphenoethmoid recess, because of these different centers of ossification, you would have giant cell rich lesions, chondrosarcomas. And something which is then going closer to the oropharynx, you would have minor salivary gland tumors. So this gives us a fair understanding whether your histology is matching with the location. And we heard from Professor Nicolai's presentation how there's a discrepancy in even the pathologies. So do not accept everything that doesn't match your judgment when you're seeing the scans. There's a need for accurate histology, and that's where I said that pathology is really important, because there are certain tumors we may not deal with. And imaging is also is a key towards understanding how we're going to manage these, right from the point that we're going to deem it as operable or inoperable and going ahead. CT MRI has to be done in all cases. And we know that surgery remains the most important modality of treatment in these tumors, which are rare, mostly non-squamous. More than 50% of these will be subcranial. So you know that endonasal approaches will be usable. More than 70% are free of dura, and more than 90% are node negative. And we have seen how the management of the various modalities with node positive and node negative helps us. So the decision making is important, and for that we need histology, the tumor spread location, orbit involvements, cranial nerve status, performance status, and other details. Generally, for stages 1 and 2, surgery or radiation is important. For stages 3 onwards, you would need a combined modality treatment. For a T1, T2 cancer, the surgery would be a medial maxillectomy with ethmoidectomy. And for the ones in the maxillary sinus, at least an infrastructure or a medial maxillectomy. For stages 3 and 4, you would combine surgery with radiation. And in the ones that are not resectable, you would offer them non-surgical modalities. So let us go to a few of the cases that I put together. A 45-year-old male, nasal obstruction since 4 months, recent onset right proptosis, no comorbidities, and the biopsy report shows an intestinal type of adenoCA. The radiologist, Deva, can you please read the scan?
So basically, I will
You
be
want
giving
lights
the-
out or it's okay?
That's fine, no problem. So there are the sets of images. I suppose they are non-contrast.
Yeah.
So I can see the tumor, which is in the basically middle and paramedian aspect of the ethmoidal, and which is extending into the nasal cavity. But I can see the superior extent, which is breaching the interskull base, and I can see the part of the minimal tumor, which is extending into the intracranial fossa, which is seen in sagittal images, and an aggressive tumor. It is also causing pressure scalloping of the lamina papyracea as well. Here, both the side, right more than left. And if, I would like to do if the contrast is must for this type of tumors.
Yeah, contrast has been done, but I haven't put it up. The surgeons, how would you all read this scan? Chirag, what are you looking for on the scans? And
I am looking for dural and brain invasion. So on sagittal scan, there is a focal dural involvement, but I would like to look more slides actually, because it is T2 image, and I am not very sure that it's only dural abutting invasion or this brain invasion. So, and also I will need contrast imaging to look for it.
so what are you looking for brain invasion or dural invasion?
Overall thickening of dura, whether there is CSF cleft is there or not, and obviously there is any brain edema or direct signs of brain invasion.
So when you are discussing, you will inform the radiologist that this is all other things that you would require in case the report doesn't contain.
Yeah. And contrast is required.
Okay. Deepa, Raman.
I would also want to look at the orbits in detail. Many times we have seen when tumors compress, it's just merely compression, the periorbita is intact, or whether there is periorbital invasion, because our surgical plan will change accordingly. We would also, since we are planning to, if we are planning to endoscopically, we also need to have a framework in mind of what sinuses are involved and what approach is it going to be. Whether it's, if it's single-sided, it's binostril, septectomy, how far you are doing it, what about the status of the other sinuses? Like it does seem that the sphenoid sinus maybe has retained secretions because the tumor is obstructing it. And then, of course, the bony landmarks from a CT scan.
So CT and MRI are very important. We need to understand whether there's a superior extension. When there's a superior extension, you would want to see for the thickening of the dura, you'd want to know for invasion, you want to see the edema in the brain, which tells you about an intracranial extension. Deepa, anything else?
So I think in addition to all the points, Ramandeep said, we are thinking about operability. We know that this is an intestinal type of adenocarcinoma, and the preferred treatment of choice is surgery. So when I
Are
look
you
at
concerned about anything in
Yes,
this?
I am. On the top left, and down, you can see brain edema. So the cuts are not complete. So we would want a better imaging of the brain as well, and we would definitely want contrast in this case
Okay.
because the brain edema is a sign that there's dural invasion. And I would like to see what is the extent of invasion, because if there's what is the lateral extent, what is the posterior extent. Both of these would be limitations for my surgical resection.
And what about pathology? You'd want Shelley to do any further tests on this?
Yeah, so I think she can discuss, but we would ask her about the grade of the tumor, and we would ask her for mutation status. But I think, again, most like Madam talked about in the morning, for the pathologist, they would always give us a comment that please rule out metastasis from other sites. So that is another important thing, because on morphology for them, it will be very difficult to say whether it's a primary sinonasal type unless we are sure that there's no disease elsewhere. But I'll ask.
Yeah, Shelley, what would you
So, as ma'am said, definitely whether it's a low grade or high grade intestinal type adenocarcinoma, if you can comment on. And secondly, rule out meds. So I would definitely go for IHC to further in this case.
So you need to know more. You want to know whether this is a high grade or a low grade histology. You want to know if it is a papillary, you know that it's a low grade. If it's on the other hand a signet ring type, it may be high grade, and that helps you in prognosticating. We also would ask you about the P53 status in this.
Yes, if P53 is mutant, it would indicate worse behavior, like aggressive behavior.
Right. Rushabh, would that change your management?
So, for me, two important things are whether it is resectable or not at this point of time, or even if you want some debulking. And second would be the grade of tumor, which would be very important for me. Generally, the lower grade tumors will not respond well. So, if our intent is to debulk, we may not be able to achieve if grade is low grade tumor.
So we are dealing with a histology which is rare. Not all of us come across an intestinal type. And in that, we want to know whether it's a low grade or a high grade. You want to know also about the P53 status. Now, this is something that is controversial, but we have seen that it might make a difference in your management. Here, our concerns are about the orbit, our concerns about the intracranial extension, our concerns about even posterior. My concern was also, as we're going posterior, is going toward the orbital apex. So am I going to get a clearance there completely? Am I really going to be able to clear the periorbita there? So that also is my concern. So if I have to address this, I'm also looking at, is there a possibility that Rusha will help me with reducing the volume, the bulk? So there have been papers which have looked at the P53 status. If it is a wild type, you know that a functional type, you know that this might respond to chemotherapy, which is in contradiction to what we understand about adenocarcinomas. We know that this is an operable disease that has to be operated. So, Deepa, you would like to further talk about P53?
So, Lisa Licitra, and I think Dr. Nikolai also showed that in his talk today. Lisa Licitra had shown that if patients have wild type T53 and they are treated with cisplatin leucovorin, then the prognosis and the disease controls are better. But again, as Dr. Nikolai has suggested that recent paper of theirs, where they looked at a larger cohort, it does not seem to have panned out in a larger series.
But what's your experience?
So a lot of them, we don't get that many which are wild type. Most of the P53 mutated in our series. And the ones which are getting a wild type, we do give neoadjuvant chemotherapy. But I think most of them still undergo surgery. It's not that it responds. They are dramatic responses, but then most of them will undergo some sort of surgery and then adjuvant RT.
Okay. So, any role for chemotherapy and Rishabh, do you have any experience in that?
Surely, sir. So, the primary purpose, especially when we want to decrease the morbidity of surgery, I think platinum-based chemotherapy can help. Compared to other head and neck tumors, we have to be more skeptical. Means we need to image probably after second cycle and see clinically at each cycle, because in oral cavity or some other cancers, we know that what the response rates are, and the data for this subset is not that strong. So we have to be careful while we give chemotherapy. But platinum-based chemotherapy is a reasonable choice for this patient when we want to debulk.
So please read up these papers that have come from this group in Brescia and in Rome. They looked at this group of patients way back in 2004, and they found that almost 80% of the patients were wild type or functional responded, and almost 40% achieved a complete path response. And the ones that achieved a path response had 100% disease-free survival at 55 months. They also evaluated the ones that underwent craniofacial surgery, and the ones that received induction chemotherapy also seemed to do better than the ones who didn't and were P53 wild type. So it may be a key to better prognostication. We don't have very large data sets, but in our experience, we have seen that these tend to respond, not dramatically, but this was the response that we saw in this patient. So how do you think it has responded?
So I don't see, I mean, there is a clear, I mean, complete regression of the tumor, near complete, I can say. There are retention secretions which are seen at the site of the tumor. And apparently I can't see now the edema also, which was there in the previous pre-treatment scan. So I would like to say there is a very good response, although the diffusions are not been given,
Right,
which is
right.
one of the very important sequence to delineate the post-treatment response. But definitely there is a good response.
So we would, in the joint clinic, look at this more holistically. And yes,
Carcinoma, anybody is using MMR? Because we are discussing P53 in the morning. I just went through, and MMR, you guys are, we are not doing, but nobody is doing. Mutant. Yes. No, is anybody doing it, using it? Not really, no? Because we are also not doing. I was just going through the literature and there are some references.
right. So maybe everything is not yet known about this because the number of cases that we each of us see is small. But this is something that we should try and get. It is possible on immunohistochemistry, and it is really not going to cost you too much. But more information might help us, downsize our surgeries. So for the surgeons now, how would you then manage this? What is your reading of the scans?
So, definitely, the tumor has reduced. Even at our institute, we had tried a few cases in which we gave induction chemotherapy. I was going to discuss one patient who had lost one eye because of the tumor. Other side was impending vision loss. It was a larger.
Adeno-CA.
Yes, sir. It was a larger tumor. And when we discussed it in the tumor board, the only issue was, should we straight away go ahead for surgery and try to, save the other eye, or should we give a trial of induction chemotherapy? We still could not answer. The patient went with the chemotherapy and he lost the other eye also.
Right. So I think we need to understand more about it before we head the path. The message is very clear that we still do not know more about this. Adenocarcinomas remain a surgical disease. But if you are getting further information from the pathologist, you might want to consider this. So based on your reading of the scans, what would be your approach? We knew that there was a edema there at the intracranial region.
Yeah. I mean, we can.
Would you consider non-surgical modality?
including,
When Devas mentioned that there's a very good response.
along the septum, if you see, and still in the ethmoid regions next to the right eye, next to the lamina papracia, is that disease or is it just, response to the therapy? So maybe go ahead, go in and take a biopsy and see what it comes out. If it's still positive, I would still do a surgical debridement, even though the extent of debridement would be much less than what I would have done if I'd taken the case primarily.
Deepa?
In these images and the sagittal, there is still the thickening, the subtle dural thickening or the part of the disease which is lying.
Right.
So I think that was my comment as well. The cribriform area is still not looking nice, and we don't have post-contrast scans. So I would evaluate the cribriform area for involvement. If there's suspicion that there's residual disease there, my preference would be to approach it surgically rather than give non-surgical treatment, because we know the response to non-surgical treatment in intestinal adenocarcinoma is less. So if assuming that is disease in the cribriform, it seems as if it is clearly resectable endoscopically in my hands, and we would do plan an endoscopic endonasal resection, endonasal craniectomy.
So everybody agrees that we would then consider doing a surgical approach, though there's been a good response. So whenever we are looking at scans, the first thing you would want to know is what is the intracranial extension. And you would want to divide them as a subcranial or a transcranial axis. You know that all your subcranial axes are feasible today to do endonasally. And for the ones that are transcranial, because you need to get a superior and an inferior control, you would want to consider doing a craniectomy, either transnasally or open. So for the subcranial pathology, the delineations are the anterior facial skeleton and the palate. And if they are free, you would consider doing an endonasal approach. If they're involved, you do an open approach. If they cross the mid-pupillary line, technically it's difficult to go instrumentation far laterally, and you would then consider either an open approach or now the newer approaches which are transorbital. So this patient has a subcranial disease, and we would plan to do, similar to this, you would plan to do a endonasal endoscopic resection. So this patient underwent a transnasal subcranial resection because the margins on the dura at that point came negative. And the final histopathology showed no residual tumor. And the biopsy slides reconfirmed it as a sinonasal intestinal type. They re-looked at the scans, slides. So now what would we do ahead, Sarban?
I think I would consider this patient for adjuvant radiotherapy because this is the status post-induction chemotherapy. So I would still consider this for radiotherapy, adjuvant radiotherapy.
So you were discussing about the changes in your radiation planning. Can you just explain what changes do you do in the post-operative setting in a patient who has responded?
So what we would do in this case is actually fuse the preoperative thing, what you call preoperative MRI that the patient had with the postoperative scans.
This just incidentally put up.
Yeah. So the thing, what you call, just because that's a right-sided tumor, right?
Yeah.
Which we had.
This is not the same. I'm just putting it up for effect.
So what we would do is actually we would fuse the preoperative imaging with the postoperative imaging, delineate the pre-chemotherapy tumor on that, and of course delineate the cavity now. Because it's an adeno-CA, we would do the level 7, that means the retropharyngeal lymph nodes in the 1B and 2 on the right side, not on the left side, on the right side only, but the bilateral retropharyngeal lymph nodes because it's an adeno-CA, but the dose that we would give, the residual thing would be about 60 gray, equivalent in 30 fractions, and the neck nodes we would only give about about 50 gray, 25 fraction equivalent. So it would receive a lower dose, but the cavity would receive a higher dose equivalent to 60 gray. So this is definitive. For adjuvant, we would give a lower dose.
Okay. So you would cover all the areas. What happens to the orbit? Now we have cleared this, and we obviously will clear the periorbiter because it was breached.
It was breached, but if you see the imaging, I don't think the orbital contents, it was intra-orbital. So we will leave it out because see, it's just going there and it's not actually involving. There's a clear plane there. So we will not irradiate the orbit. The nasal mucosa is what will be irradiated properly, the nasal mucosa and the ethmoidal sinuses. So the orbit should be spared actually. And so also the optic nerves and the optic chiasm.
Okay. Any questions from the audience so far? Yeah, Harsh.
Pre-NECT scans, we saw that there was like a little bit of posterior extension onto the planum. And would that ever be a concern because reconstruction of the skull base there is an issue? So would that be an indication for NECT?
Yeah, so the question he is asking is the pre-treatment scan showed that it was going onto the plenum. So would you have any concerns during surgery for reconstruction, Chirag? Because you're going to resect the plenum, you're going to resect the dura on the plenum. So would there be more concerns, and would you then push you towards considering induction chemotherapy?
No, basically, even if the dural defect is there, I think it will be very small and it will be manageable even endoscopically.
Okay.
Oh, sorry, means.
No, we are going to do it endoscopically, but how would you have concerns for reconstruction and leak, CSF leak thereafter?
I think it should be manageable with this. Yeah, relatively smaller one.
So definitely with the lesion, the kind of scans we saw when they especially involve the septum, harvesting a Haddad flap goes out of the question straight then. But luckily, like we had discussed in the morning, there's a plethora of reconstruction flaps available in the nasal cavity, and the inferior turbinate was spared. So you can go ahead and use an inferior turbinate flap also.
Okay.
And then, of course, if the cartilage from the nasal septum is not available, conchal cartilage works equally well to fill in the spaces. So even if I have to drill out the planum and a space is created, I would take a,
But for malignancies, would you still do cartilage reconstructions?
Cartilage is basically, so what we have seen in reconstructions is that it is just how do the defects heal? They heal by nasal mucalization. So it's not that the dura is going to regenerate. So basically that just acts as a partial support. And of course, after radiotherapy, we have seen that the cartilage necrosis, and we have had cases of CSF leak. But that being said, we need to keep all those things into consideration. Put a cartilage, put a vascularized inferior turbinate flap. We can tend to overdo because we know shrinkage is going to be there. Necrosis is a clear-cut possibility. And of course, post-operative CSF leaks are a possibility.
Okay. Deepa?
So I think the question was about the dura at the plenum. So that's one of the reasons why the first comment was that we need to assess it with the proper contrast enhanced scans. We look at both the pre-chemo contrast enhanced scans and look at the type of dural enhancement, whether it's linear or nodular. If it's linear, you know that this may be reactive. If it's nodular, it's definitely involved. Post-NECT, if it was a linear enhancement pre-NECT, post-NECT, most of the times that enhancement will go away and you will be reassured that you can resect the plenum. But if there was nodular enhancement pre-NECT, most of the time, reaching the plenum, most of our times, the decision would be upfront to give induction followed by chemoradiation. We are concerned about repair at the plenum. Because for the sheer fact, if you have a positive dural margin, your optic chiasm is going to be a limiting factor for repair. And if you have unhealthy dura, whatever repair you do, it's going to break down. We've had, unfortunately, one case where we had a case, the same thing. Though we went in assuming that the dura was healthy, the dura was not healthy, and the patient kept having leaks and meningitis and unfortunately succumbed. So I think we learned from our experience and we are more hesitant. If there's frank nodular enhancement at the plenum, we would consider this patient for non-surgical treatment.
Okay. So we'll go to the concern, Harsh, is that you would want to resect it because it's an adenocarcinoma. You would want to consider surgery, but you would want to use a vascularized flap, make a pericranial vascularized flap and cover it so that you do not encounter the leakages.
So if the other side of the nasal cavity is fed, you can harvest the hadart from the opposite side. And another thing, at the plenum, the dura is very adherent, specifically in older patient. The dura will be very thin and it will be adherent to bone. So while you are elevating at the plenum, you will make the tears, multiple tears, which you will not appreciate at that time, but later on you will appreciate that CSF leak is there. So be very careful while you are dissecting the plenum dura. Otherwise, you can do one thing, endoscopic go nasal through the nasal cavity and deal the repair from the cranial side.
Agreed. Any comments? Anyone from the audience? Okay. So we'll go to the next case, a 35-year-old homemaker, idiopathic thrombocytopenia, right eye proptosis since 8 months and nasal block since 6 months, being conservatively treated. The biopsy shows an inverting papilloma. Patient has normal vision and eye movements. So, Deva, can you read the scan? I know it's just one, two scans.
Basically, there is a typically cerebriform pattern which we can see here in the tumor, which is involving the right sinonasal cavity, involving the frontoethmoidal recess extending into the frontal sinus. And there is a breach in the the roof of the orbit, which I can see on the post-contrast scan. And the tumor looks adherent with the conal compartment of the right orbit. So, and yes, I can see some reactive dural enhancement, which is seen at the intracranial fossa on both the post-contrast scan. So, looks
So
aggressive.
would you have any concern that this looks more invasive than a
Yes.
regular inverting papilloma?
Yes, it looks invasive.
So what would the clinicians ask for? Do you want to repeat a biopsy? Are you going to be concerned about transformation?
As a neurosurgeon, along with dura, it looks like there is a mild brain invasion is also there. So it will be needed to be considered while we do the surgical planning.
Okay. Deepa, Raman? Would you repeat a biopsy?
So I would repeat a biopsy, but the only issue is that if you can go back to the coronal images, if you see the component which is in the nasal cavity, will possibly is not the malignant component. What looks like the malignant component is where there's bone erosion, which is in the frontal sinus. So a repeat biopsy from the nasal cavity itself may not give you that diagnosis of SCC. You would have to be very careful that when you do your biopsy, you take it, not do a office biopsy, but take it into the operation theater and try and assess and not just take polypoidal tissue, but try and take actually tissue which looks more aggressive. The other way would be maybe do a needle biopsy. But even if that, it's not a routine thing, but if you think, if there is, I can't see the clinical picture, but sometimes you have the lesion actually coming, and we've had a couple of cases where the anterior wall of the frontal sinus was eroded and it's coming under the subcutaneous tissue. In that case, you may be able to take a diagnosis if you can't get a biopsy and you need to start chemotherapy for this patient.
Okay. Shelly, any other way you can help us?
Because I think the clinical and the radiological picture looks quite invasive, so we definitely need to look for squamous cell carcinoma rising in the background of inverted papilloma.
Any IHC markers that you would do?
So low risk HPV is, people say that EGFR and low risk HPV by RNA-ish could be done, and if low risk HPV is positive, they have more chances of converting to squamous cell carcinoma.
Okay. There's also some DEC-F8.
Yes, DEC-AFF, and so if we have an antibody running an AFF2 antibody on this would help us confirm that diagnosis on biopsy itself.
So there are a lot of ways that the pathology can help you today. And if you are suspecting that looks odd, it's not an inverting papilloma, is looking more invasive, you need to ask your pathologist to do more. And today, everything is changing. In the last 5 years, the pathology has really dramatically changed. So this can be diagnosed as a squamous cell transformation. So this was a moderately differentiated squamous cell transformation. And it was reaching here. So is there any concern for the surgeons? Sarbani, would you have any discussion for giving chemoradiation upfront? And Rusha, would you consider giving chemotherapy upfront?
I would think that this patient would be a little touch and go even for the surgeons because superiorly it doesn't look very good and clean. I think if there is residual disease left behind, it would be at that frontal sinus level and not inferiorly. So I think it may be important for the surgeon to then think about doing some kind of induction therapy and then, depending on the response, decide what to do next. I know it's an inverted papilloma with squamous carcinoma. We really don't know whether it's going to respond. But I think because at that level, there may be a problem with the getting clear margins.
Deepa, any other concerns? Orbit and all looks clean.
No, orbit is a definite concern. I would want more imaging and I would want my radiologist input on how much of the muscles are involved. To me, it still possibly is extracorneal, intraorbital extracorneal, but we would need to look at all the, yeah. We'll have to look at all
we are
the scans.
concerned about the orbit, we are concerned about the dura, we are concerned about
The posterior table of the
Posterior
frontal
table.
and anterior table of frontal sinus is eroded.
Yes.
So all of these are concerns. This to me, in view of the histology, would be not a candidate for upfront surgery. I would definitely consider induction in this patient for
Okay.
two reasons. One, I would want to see if the tumor downsizes and I can attempt an orbital preservation if possible. And second, it will give me an idea about the biology as well.
Rusha, would you give chemo and if so, what?
So, platinum-based chemotherapy, preferably 3 agents. That is what, because this is a squamous cell carcinoma, it would be behaving what other head and neck cancers would. So, because R0 resection looks difficult or it is morbid, I would give NSCT.
So there is a lot of evidence, and Professor Nikolai also showed in his presentations the various responses that we are seeing now. And this is based on a lot of data published way back in 2011 from the MD Anderson. And they found that there's almost 70 to 80% responders. And the ones that respond actually have a long-term survival, which is better than the ones who are non-responders. So in these kind of cases where your concerns are about resection and clear margins, you would want to consider neoadjuvant chemotherapy. Is there any other possibility of, now with the induction chemotherapy, immunotherapy coming in, would you want to consider immunotherapy in this?
So, sir, in squamous cell carcinoma, we have data for perioperative immunotherapy in operable disease. But in TMH, outside TMH, we have used a lot of low-dose Nivo with some form of chemotherapy. There is CMC data of this. All is for oral cavity or oral cancers. But we don't have data for specifically for such patients of nasal cavity where it has been transformed from inverted papilloma. But I have a gut feeling that it will work. Same as in squamous cell carcinoma of oral cavity.
I think we were at the INSICA meeting over last weekend, and Glenn Hanna is leading a trial where he's looking at toripalimab as neoadjuvant immunotherapy in sinonasal cancer. So it's a study planned for 2 years. So I think there are going to be more studies in this space, but we don't have any evidence right now to suggest that immunotherapy should be given in the neoadjuvant outside of a trial setting.
So, and also more molecular pathology is coming in. So we know that many of these will have exon 20 missense mutations, and you would want to consider the targeted therapy as well. So a lot more in this space is coming up, and we need to look at the ones that are high risk for local failure, difficult treatment options. And in these patients, you would want to do molecular studies as well. So there are targeted therapies also for these kind of treatments. So any questions from the audience? Okay. So let's go to the third one. 35-year-old male, the essential neuroblastoma, which is a Himes 3. This is a Kaddish C. And what would be our line of management? Surgeons?
I actually want Diva's opinion on
Okay.
the enhancement along the forks.
So that midline fox is, I mean, although it is seen to be a nodular enhancement, but since there is no edema or anything, but I would like to have if more sections, but similar enhancement which we can see on the left side of the parietal, which is bit thinner, but I don't see it is. I mean, I don't think it is involved. Just a proximal part of the midline, which looks maybe a reactive dural tail or the nodularity, which we can see on the sagittal. Yes, yes. So that looks involved.
Okay.
Yes, I mean
What
it is a
about
gray area which
Okay,
looks.
that's a gray area.
Yeah.
Orbit.
Yes, it is. Its paraorbita looks on right side irregular, and the enhancement is also bad. So looks involved. I mean, not just a pressure effect. It looks involved.
So what would be your plan in the joint clinic? This is a Himes 3 and it's a Cadis C.
So again, assuming there are no distant metastasis in this
So
patient.
you would do a PET scan.
Definitely. It's a Cadis C, Himes 3. These are the higher chances of distant metastasis at presentation. So before we plan any curative intent, we would always get a PET scan in these cases to have an evaluation of the distant metastasis.
Okay.
So assuming that there are no distant metastasis, the concern again would be for me is the midline sagittal FOX involvement, but we would go ahead with a plan of induction chemotherapy in this.
Rushabh, what would be your plan if they ask you for induction?
So for this, generally we give cisplatin etoposide as a neoadjuvant chemo, and we would image somewhere around second to third cycles based on response, and then take further decision.
Okay. So we gave 2 cycles of chemotherapy and this was the response. Sorry, these are all the 3 scans I have.
Responded basically, if we talk about the nasal aspect, yes, I can see the tumor which is still seen in the cranial fossa, and I can't comment specifically for, so it is partially responded.
It is partially
which is, we
responded,
can see
right.
it. And basically the orbital component has regressed, which is seen here. But
The
again, the gray
intracranial
areas.
component seems to be
Yeah,
similar,
Yeah, but it is
but
there.
that dural tailing
It is-
seems to have reduced.
It is, but
So-
it is still there.
Yeah. So what would the surgeons now, Raman and Chirag, how would you plan this?
I
The
think,
orbit seemed to have cleared.
yes, and if the vision is normal, that's a
Vision
good,
was normal and it
so
still
that's
remained normal.
that's a good thing because that takes a lot of stress from our from our surgical planning. Whenever there's an intracranial esthesioneuroblastoma, we operate with the neurosurgeon, that is with Apinder. If it's widely involving the cranial cavity, we prep for both approaches. He opens from the top, I go endoscopically, and then we reconstruct the skull.
So in this case, would your concern be endonasal craniectomy or an open
I
craniectomy?
think this we can get away with an endonasal.
So what criteria would you put forth for planning an endonasal craniectomy?
The tumor has responded with the radiotherapy, with the induction, and we are dealing with a lesser bulk of tumor excision. Plus, I would also see in these cases we usually like to see the CT because I would like to reconstruct the skull base post the surgical excision also, because that is also very important. Other than that,
Dura, any concern with dura?
dura usually, if we open it wide enough, we can, resect the dura and then we reconstruct it.
Specifically, since she's raising a doubt about the dural tailing, would you be concerned about achieving a negative margin? Because we have seen from morning that a negative margin goes a long way in a better
the
outcome.
long-term longevity of the patient. Yes, that would be a point, but I would still, attempt endoscopic.
Okay.
endovasal.
Chirag? Because we are going to open and give you.
As far as dural involvement is concerned, it is more approachable transcranially. So I think craniofacial resection will be better option.
But you would keep both options open.
Yeah.
Okay. Deepa?
Again want a CT scan in this, and that is because of the frontal bone. If you see anteriorly, there's some soft tissue there, and I'm not very clear whether there's erosion there. So I want to see if there's erosion.
Okay.
So if the anterior most edge is eroded or I need to take a margin, then maybe we would do a combined craniofacial approach in this. Because if I'm not going to get a good anterior margin, or for me the repair is going to be challenging endoscopically, in such a case, because of that anterior beak of the frontal which is seeming to be involved, and according to the why it is, then in that case I would call my neurosurgery colleague and plan it as a combined approach.
So it's very important to, subdue yourself, your enthusiasm to do everything endoscopic. A clear evaluation is very important. Dural elevations going laterally, dural elevations going beyond the midline, mid-pupillary line, inability to clear that dura, form the nasal cavity, should not stop you from doing an open procedure. So you should always plan this, as I agree with both my colleagues here, you would plan for an open SOS, endoscopic SOS open approach. So in case you're not getting a clearance, you would do a formal craniotomy and clear. Ali, any comments?
I still remember a case we did with the pin. Now the problem with that anesthesia was it entered from a very narrow neck, but once it was intracranial, it was spreading bilateral far laterally.
Right.
So that was a no-go for a pure endoscopic approach.
Right. Great. So I think, yeah, Upinder.
I agree with sir. One point is which is the enhancement of the FOX, which we will not be able to achieve through the endoscope. And secondly, of course, if the tumor is invading into the brain, I mean, usually they're extradural lesions, but if at all they go into the brain, then the brain is very much odematous. And you end up landing in part of the resection of the frontal lobe as well. And extended bifrontal approach can easily take care of the FOX, anterior FOX, which you can move along with that. So we can achieve an R0 resection with that.
Agree.
So
agree. Yes.
Pericranial reconstruction.
Can you give a mic, please?
And pericranial reconstruction, I mean, you can take a fascia flap and extrudize the frontal sinus, and that minimizes the CSF leak as well.
You would do a pericranial flap. I mean, even you can, like Professor Nicolai talked about, making the burr hole and then putting the pericranium through that.
No, but like in the frontal sinus,
we do an endonasal.
Yeah, endonasal is fine. I was talking about the extended bifrontal approach. In that case, we'll need that.
Professor.
Yeah, I believe that as we discussed, we have to mitigate our enthusiasm, because if we look at this patient and the presentation at the imaging at the MRI, and we consider, for instance, the patient I presented this morning, which was a grade 2, they are completely different in the interface between the brain and the tumor. Yes, there was a response, but the findings we have seen at presentation, we have to keep in mind. And then we have to ask ourselves, we will be able to get really an examination of the margins that is giving us the proper information for deciding if the endoscopic approach is enough or it's better to go ahead with the front. We are doing usually a subfrontal approach.
Like a Raves.
Yeah, a subfrontal approach, and I believe that you can have, even with the subfrontal approach, a nice exposure. And my concern would be with the folks, because I believe that in spite of what you see, probably if you want to be radical in this patient, even after the results of induction chemotherapy, would be better to extend the dural resection to the folks and bilaterally over the orbit, but especially on the right side.
Thank you very much. I think we are short of time. Thank you very much. I thank the panelists for a very active interaction. Thank you.
I would request all of you to come forward for a group photo, please. Thank you all.